Thanks for joining us tonight. Tonight's lecture will be given by Dr. Chad Krueger, who is a fellowship-trained, board-certified orthopedic surgeon specializing in hip and knee replacement surgery. And Dr. Krueger sees patients in our Abington, Bluebell, and Willow Grove offices. We will be recording tonight's lecture, so we will send it out after tonight. And if you do have questions throughout the presentation, you can enter them in the Q&A box at the bottom of your screen, and we will take time at the end to answer.
Excellent. Thank you, Natalie. As she said, my name is Chad Krueger. The title of this talk is the most common questions people ask about total hip and knee replacements. And then, some of the questions I would ask if I was getting my hip and knee replaced as well. So although certainly add anything to the comment lecture as you like, I'd love to ask questions. I want this to be a pretty open discussion. In general, I'm pretty non-prescriptive with most of the advice I give to patients. Every individual is a little bit different in that regard. And I do want this to be as much conversational as it can be. So by way of disclosures, I don't really have a whole lot. This is our mandatory disclosure side. So these are my thoughts. They don't represent other surgeons' thoughts or those of Rothman necessarily. So again, the goals of this talk are to really answer some of the most commonly asked questions that I hear from patients, and then also some of the questions I would ask if I was getting a joint replacement. I do want it to be conversational. And again, these are only my answers. You talk to 13 surgeons, you're going to get 13 different answers. Hopefully, we're pretty close on some of them, but again, some of the specifics may differ. So a bit about myself. So as Natalie mentioned, I do hip and knee replacements and reconstructions. I do simple, relatively cases, which are the primary joints. So primary hip and knee replacements, meaning that you haven't had a surgery before. And I also do the most complex stuff that you can see. So patients who have had multiple surgeries on their hip or knee replacement, I take care of those patients as well. I've been in practice since 2015. My offices are in the Abington, Willow Grove, and Bluebell areas. And a little bit about me. So I got a wife and 2 kids. My son's almost 8 and my daughter is 5. So we live in this area and have enjoyed being here as well. So just to start a little bit basic, what is a hip or knee replacement? I really wish that when they had started developing these back in the 70s, that they had just called them a resurfacing. It's a lot less intimidating and probably a lot more factual in terms of what we do. As you can see by this diagram, so the before picture, you have some worn out cartilage on your knee, which is the end of your knee joint. Cartilage is a nice smooth surface that has a very low friction, but as that wears down, the underlying bone gets exposed and it's very painful. And it's the same process that happens in the hip. When we do a knee replacement, you can see that we shave off that worn out cartilage and then basically put a cap on the end of your femur, which is the end of your thigh bone, and on your tibia, which is the top of your shin bone. We do the same type of thing when we're doing a hip replacement in the sense that we remove the arthritic areas and then give you a new ball and socket joint. So again, we're not removing huge parts of bone or anything like that and leaving you with a big chunk of metal in any of your joints. We are really resurfacing it. And if you think of it like a cap that you'd have placed on a cavity, I think a lot of people are familiar with those. And that's really the same purpose. We're removing the bad tissue in your body and then putting a metal cap over the top in order to try to give you a joint that doesn't hurt. So the first question I get asked the most commonly is, when do I need a joint replacement? And the bottom line is I can't tell you. There are people with horrible looking x-rays, meaning that they have really severe arthritis of their knee or their hip, and they walk around, they don't have any pain, they do the activities that they want to do, and I would never recommend replacing a joint like that, okay? I can't fix something that isn't broken, and I can't make someone feel better if they don't have pain. The entire point of a hip or knee replacement is to improve your quality of life, okay? Just because you have a horrible looking x-ray doesn't mean you need a joint replacement, okay? In the same token, there are patients that don't have severe looking arthritis on their x-rays who have tried every type of non-operative treatment, which I'll get to in a second, and have not done well. And then I do a joint replacement on them and they do very well. Okay, so there's not a cut and dry answer in terms of when a joint should be replaced. Again, the main question I would want everyone to ask is, how much is my quality of life impacted by this arthritis? Do you no longer go for long walks that you enjoy doing or playing pickleball? Or do you not want to get down on the floor with grandkids or children anymore because your hip or knee bothers you from doing those? Conversely, maybe you don't walk as long anymore. You still go for walks, but your knees bothering you, your hips bothering you. Okay. Those are the types of things that we can improve when it comes to a hip and knee replacement. In the other aspect of this is that I can't change what you've already done, right? So, if you walk in and you're like, look, my goal is to run again. And then I ask you, well, okay, when's the last time you ran? And you tell me back in high school, 30 something years ago, it's unlikely you're probably going to progress to being a runner again. So I can't reverse your knee or your hip back to when you were 18 years old. Again, the whole idea is to let you enjoy the quality of life that you're looking for without so much pain. So the main question I want people to think about is, what brings joy to your life? And then if that joy is being impacted or prevented, secondary to knee pain or hip pain that's caused by arthritis, then we go on with some non-operative modalities first, such as anti-inflammatories or Tylenol, ice, activity modification, things along that nature. If those don't work, you can also get injections, okay? Injections are used, typically a corticosteroid is what we try first, although you can have a viscosupplementation or a gel or chicken fat injection as well. None of those injections actually improve your arthritis. Just like the anti-inflammatories you would take by mouth, those injections are designed to help decrease your symptoms, but they don't replace your cartilage. They aren't a fountain of youth. So they're just aimed to alleviate your symptoms so that you can do what you want to do. Once those injections aren't working, okay, or if you have very severe arthritis, in which case the injections may not work well at all, that's when we start talking about a hip replacement or a knee replacement. So hopefully that kind of makes sense, but those are kind of the questions that you need to ask yourself and that I'll ask you when you come to the office and we start having these conversations. Another common question when we are talking about hip and knee replacement is how many joints do you perform? And basically what you're asking the surgeon is, do you know what you're doing? And that's a very reasonable question. You only get 2 hips, you only get 2 knees in life. And if you're going to get them replaced, you want it to be done well. And you want to make sure it's someone who's, not just starting to do hip and knee replacements and doesn't really know what they're doing. As an overall practice, Rothman Orthopedics does about 17,000 hip and knee replacements each year. So we are a very large center, and we do a lot of hip and knee replacements. That's what I'm trained to do, and that's what a lot of my partners are trained to do as well. Almost all of the hip and knee replacement surgeons here perform about 20 to 30 hip and knee replacements each month. That's in line with what I do as well. So it's about 600 or so cases a year. Some people do over 900 a year, okay? In general about myself, about 25% of my cases are revision surgeries, meaning that I'm replacing a joint. So someone had a hip or knee replacement already, and they need an additional operation. So about a quarter of my patients are those. But again, the vast majority of my patients are primary hip and knee replacements, meaning that it's the first time someone's getting a joint replaced, okay? Along those lines, there's a lot of different techniques that surgeons will use to replace a hip or a knee. The bottom line is each surgeon is going to do what they feel works best for each patient, okay? So we're all, myself, excuse me, myself personally, when it comes to, say, hip replacements, almost all of my patients, I do a direct anterior approach on, okay? In fact, I can't think of one that I've done in the past year that hasn't been a direct anterior approach, but I'm also trained in direct lateral approach or the posterior approach. And there are certain situations where one approach may make more sense than another, all right? That being said, you want to choose the approach, or the surgeon's going to choose the approach they think will work best for you. It's kind of like math when it comes to these things. As a joint surgeon, my job is to understand very basic principles and also some complex principles so that when it comes to a specific problem, I can solve it, right? You may never have added 2 numbers together before, but if you understand the premise of addition, you're going to be able to figure out the problem. And that's what someone like myself and my partners are able to do. Another common question that I would ask personally is, deciding who would take care of me. Which surgeon do I want to do my hip and knee replacement? There's so many that are done. And I'm sure a lot of you have family and friends who've all had hip and knee replacements done by various surgeons. I think for myself, it would come down to trust, right? At the end of the day, it is a patient-physician relationship. And you want to make sure that you're comfortable in that relationship, because the vast majority of the time, everything goes very well. Patients are happy. We give each other a high five. You move on with your life once you've recovered from the hip or knee replacement. But if something isn't going well, you don't want to be second guessing yourself as to, I didn't have a great feeling about this going into it. I shouldn't have done this, or something along those lines. Okay. That's what you want to avoid. The surgeon is there to help you. And you want to make sure that you have a relationship with the surgeon and their surgical team to feel comfortable in the process of going through it. Because at the end of the day, you have to trust the surgeon. You aren't helping me during the case. You are asleep or out of it, if you will, depending on what type of anesthesia you get. And I am replacing your hip or knee, and you have to trust me to do that job, okay? Other questions I would ask is, what are some of your most common complications? The most common ones that I talk to patients about are infection, okay, which is, I think if you asked any joint surgeon, that would be their the complication they try to hardest to avoid, okay? For knee replacements, it's about 1% in our practice. For hip replacements, it's about 0.5% on average, okay? There are certainly some patients who are going to be more prone to infections than others, depending on what their medical comorbidities are, what their health status is, if they've had infections before. But that's certainly a complication that I talk to my patients about. Other complications are going to be a bit surgeon or procedure specific, right? With hips, you worry about hip dislocation, okay? You could worry about fracturing, and then limb length discrepancy, making sure the limbs are the same length. And I would go over with your surgeon how you can determine, how to decrease the risks of those in each setting. For knee replacements, it's more continued pain or stiffness after surgery, or the need for a repeat operation for some reason, okay? Again, a lot of it is going to depend on you specifically and kind of what you're coming in for, where you're at in life. Certainly a 40-year-old getting a knee replacement is going to be much more likely than a 90-year-old getting a knee replacement in terms of needing another surgery later in life if the components were out. Those are the types of things that you can ask your surgeon depending on what your situation is. In general, hip and knee replacements, about 80% of them last over 20 years, okay? That's a generality. We certainly think we've improved the implants than what were being placed 20 years ago, but we don't have the actual data of that time frame to tell you that, yes, the survivorship rate is much higher, okay? The other thing I'd want to ask my surgeon is, what will my post-operative course look like? How often am I going to see you? Am I going to see you later that day? Are you going to see me the next morning? You're going to talk to me on the phone? Things along that nature, all right? I don't like when patients are like, I wasn't sure what was going on, or, even when they look super surprised to see me again, they're like, oh, I didn't think I'd see you again. I don't want you to feel abandoned. And those are types of things that I really try hard to communicate with my patients preoperatively, and just so they can understand that, yes, I'm going to see you, I'll do your surgery, I'll round on you later in the day, that surgical day. I typically will see you the next day, or if you go home the same day, I'll typically give you a call the day, like the next day or the day after that, just check in and see how you're doing. I would say the majority of my hip replacement patients will go home the same day. When it comes to knee replacements, it's probably about 50-50. They don't go home the same day, okay? But that doesn't mean that I'm not in communication with you or that you can't get a hold of me. Part of my preoperative discussion with patients is they get a whole packet of information from me, and that packet is filled with information. It has phone numbers for myself, my scheduler, my nurse. You can also has numbers for the finance office if you have questions about what you can expect from a bill standpoint. It contains some of these most common questions that patients ask. In addition to what you can expect post-operatively, it has some exercises that you can work on. So those packets are designed for the patients and your families so that you can try to have as detailed an understanding of what is about to happen to you from the surgery through the recovery period as possible. I would much rather you call me preoperatively and ask questions, okay, than be concerned about something going through the surgery or asking it post-hoc and wishing you'd asked it sooner. Again, it's a relationship. It's based on expectations and communication. And I can't answer questions that you have if you don't ask them to me, okay? I do hip and knee replacements all day, every day. I do not expect you or your family members to have the same level of understanding or detail that I do. That's part of my job, and my team's job is to try to help you understand that. It's much easier going through things, being on the same page, than trying to put things together after the fact, okay? The other thing I would normally say is, or normally say to a surgeon if I was getting a hip or knee replacement, is I would say, I want you to do exactly what you would normally do for a patient like me. I don't, I may think a certain implant, may be better in certain situations, or a certain approach would be best, okay, because that's what I do, and obviously anything I do is best. But I don't want a surgeon doing something like that on my knee. I want them to do what they think is best for me, the same way they would treat any other patient. So I say that because it's about being cared for and not really about specific techniques. There's a lot of different ways to do a very good hip replacement. There's a lot of different ways to do a very good knee replacement. You want the surgeon to do what they would normally do to get a good outcome for yourself.
Dr. Krueger, if I could just
Yeah.
interrupt you, we have a question about the last slide with the
Perfect.
with the different approaches. The person said, when does the choice happen about like the different approaches and the different procedure options?
Yeah, so so for knee replacements, everything's through the front. I mean, there's one approach to the knee for the most part. So I imagine they're probably talking about hip replacements. Again, I'm a direct anterior approach hip surgeon. Even most of my revisions are done through the direct anterior approach. If there was a situation where, you know, the patient came in with something and I thought a different approach would be better for them, I would talk to them about that in the preoperative visit. Okay. Certainly during the preoperative visit, I would tell you, yes, I'm going to do a hip replacement. It's going to be in front of your thigh. It's an anterior approach. So all that conversation I have with the patient preoperatively. I certainly would not want the patient waking up from surgery and then looking about their hip, trying to figure out what approach I used. So that would be a discussion you would have preoperatively. For myself, again, everything is direct anterior. If I had to deviate for that, then I would let the patient know.
Okay, thank you.
Absolutely. Thank you for the questions. And again, please, you know, share whatever questions you can. Actually, here I got them pulled up now, Natalie. So do you mind if I read through the questions we have so far?
Ahead.
All right. Physical therapy, I'm going to get to in a second. So in terms of this is from Gail as well. So will I need to stay in the hospital overnight? I'm afraid of the pain going home. So it's a great question. So again, about 50% of my patients for knee replacements will go home. About 50% will spend the night. Certainly, if you were to go home, we need to make sure your pain's controlled. Okay. You actually do physical therapy in the hospital. You have to go up and down stairs, demonstrate safety with a walker. Everyone starts with a walker initially. Okay. I don't care if you're 30 years old or 90 years old, you're going to get a walker to start with. And then you get rid of the walker and progress to a cane or nothing, depending on how quickly you recover. I don't show up to your house and give you a medal for getting rid of the walker on the second day post-operatively or the second month post-operatively. I really just want you safe. The biggest issue that people get into with hip and knee replacements in terms of having complications is falling, okay? Your body is learning how to walk again after a hip or a knee replacement. I do not want you to fall. This is, you know, the same conversation I would have with someone post-operatively and preoperatively is I need you to be a reasonable human being after the surgery, okay? We are a team, and I'm going to tell you some things that, you know, I want you to work on, like get up and move about, maybe work on range of motion if it's a knee replacement. But the main thing I don't want you to do is fall. And if you're having a thought in your head of, you know, I wonder if I should be doing this, the answer is probably not, okay? So I don't want you to try to test things out. Your body will let you know how you're progressing so that you can feel comfortable doing what you're doing, okay? But I don't want you to try to jump off a ladder, you know, 3 days after surgery, just to see if your hip or knee can tolerate it. That's a recipe for disaster. It's not going to help you out. The body does need to heal. Okay. So that in general is kind of what I would tell someone about that. In terms of pain, I tell every single one of my knee replacement patients that the first 2 weeks are miserable. Okay. It's not fun. You're going to have swelling. You're going to have pain. Sleeping is going to be challenging. That's what you can expect in the first 2 weeks after surgery. Hip replacements, it's certainly a bit of an easier course generally, okay? You don't have as much pain, you don't have as much discomfort. After 2 weeks, that pain will certainly improve, okay? And by 6 weeks, you're feeling pretty comfortable in most situations. You're not perfect, but you're feeling pretty comfortable. It takes about a year to fully recover from a hip replacement and a knee replacement, simply because the biology takes that long to heal and for you to develop the strength and so forth. But certainly in the hospital, you're going to have pain. At home, you're going to have pain. You can expect to have pain after surgery, just like you can expect to have pain after you roll your ankle, okay? It's certainly a bit worse when it comes to a knee replacement. Let's see. Let's see. Someone asked if they were going on a trip in December, thinking about having surgery in the fall. So traveling on a plane after surgery, I would do I would say the general rule of thumb is I want patients to stay around for at least 2 weeks to make sure you're doing okay. I see my patients back in the office 2 weeks after surgery, look at their wounds, answer any questions they have, make sure they're progressing. Ideally, you wait 4 weeks, just because at that point you've stopped the medication we give you to decrease blood clots. At the same time, is there a difference, between traveling on a plane 3 weeks postoperatively and 5 weeks postoperatively? Probably not. But some of it will depend on how you feel. What I don't want people to put themselves in a situation to be is, if they have a honeymoon trip planned for, Bahamas 4 weeks after surgery, that puts a lot of pressure on your recovery, and everyone does recover a little bit different. So I don't want you to be stuck, and uncomfortable on that vacation. I don't want you to try to rush your rehab or your recovery for that matter, to try to make it onto a set date. So you want things to work in life. Surgery is surgery. You can have complications. You don't want those. But you also don't want to set yourself up to put yourself in a situation where they could become a bit more common. Anthony, yes, direct anterior is what I was talking about when it came to the hip approach. That's what I use on my patients. Kathleen, I apologize. I'll answer. What does TJA? TJA means total joint arthroplasty. So either a hip or knee replacement. Thank you for that question. And then Jean asked what factors go into the decision about staying overnight or going home the same day. There's 3 main factors that we care about. 1, I need to make sure that the patient's pain is controlled. 2, I need to make sure that they've cleared physical therapy, meaning that they've worked with a therapist, they've gone up and down stairs, they've demonstrated that they're able to care for themselves. And then 3, I want to make sure I'm comfortable with them going home. Okay. So, if a patient say had, a cardiac history, okay, and I think it's best for them to spend the night, I'm going to have them spend the night so I can watch their heart. Sometimes it'll do the same with patients with kidney issues or some other medical conditions that patients have. And they may really want to go home, but if I think it's in your best safety, I'll tell you that you have to stay in the hospital. Jeanette asked, in terms of approach, I've been told the recovery is easier and faster when done from the front versus the back. Is that correct? So again, I'm biased because I do a direct anterior approach because I like the approach. We do have some data suggesting that the first 6 weeks, the recovery is slightly faster with the direct anterior approach than a posterior approach, but we don't have any long-term data showing that the direct anterior approach is better than the posterior. So hopefully that answers your question. But again, I am biased. I do a direct anterior approach, but I also know very good surgeons that do posterior lateral approach, which is the back approach. So I by no means am I saying that approach is wrong either. All right, here, let me continue on, and then I'll answer a bit more of the questions, but I do appreciate them. So certainly keep them coming in. I promise we'll have a lot of time and I will answer every question that is there before I end this talk. Where should I get my joint replacement surgery? So I would ask the surgeon, where do you think I should go? I do operations at a large hospital, okay, Abington Hospital. That is where some of my sicker patients go, simply because they have levels of care that aren't provided at some of the other hospitals that I work at. I also go to the Rothman Orthopedic Specialty Hospital in Bensalem, and then the Doylestown Ambulatory Surgery Center. The specialty hospital and the surgery center, those are typically patients that are healthy. They don't have a lot of medical comorbidities. Most of those patients are able to go home the same day. And those are hospitals that are designed for hip and knee replacement, okay? Abington Hospital, again, very large tertiary care facility. That's where I do most of my revisions, just because they're more complex procedures. I expect the patients to spend a little bit more time in the hospital. And if someone has, a liver transplant or severe kidney disease and they need a specialist, okay, Abington has those available, whereas the other hospitals don't necessarily have like those specialists right there in the hospital. So those are the types of things that go to my planning when it comes to where patients should go. Some people, they want to go to whatever hospital is closest to them, and I understand that completely. But what I try to tell patients is, you got to think about this, right? Like, we're replacing your knee or your hip. And a lot of patients don't think twice about driving an hour to the beach and then coming home the same day. and yet they're skittish about driving an extra 20 minutes to go to a different facility that I think may be best for them. And when you think about it from that perspective, again, we want to provide you the best care possible. And in some situations, the hospital can matter for that. Okay, so that's really my short answer in terms of where should I get my hip replacement, or why do you think I should go to each facility? And by all means, if the surgeon's doing your surgery at a facility, and you're like, I prefer to go somewhere else, ask them or ask me, right? Like, hey, I'd like to go here. Why don't you think that's best, right? And I'm happy to have that conversation with them. Sometimes it's also availability. We only have certain OR time at each facility. And if you want to get your surgery done on the third Monday of a month, and I don't work at that hospital that week, then I can't take care of you. So, those are all things, again, that do go into where the joint should be, where the joint replacement would take place. Another question that I would ask personally is, what happens in the case of a complication? Again, if nothing else, just to have that conversation about what complications are possible. Obviously it depends on what the complication is, right? Everything could be a little bit different, but I want to have a general idea that, I'm going to be cared for in some planned manner. But a lot would depend on the specific complication. But it would allow you to have that conversation with the surgeon about what could happen and what would go on in that respect. Again, complications are not very common after hip or knee replacements, but it's obviously what every patient worries about, because everyone's heard stories about X, Y, or Z happening to their family, friends, and that's a conversation you want to make sure you feel comfortable with the surgeon. Again, it is a relationship. This is part of it, and you want to ask those questions that may make people uncomfortable, just so you can be sure you're on the same page. And then, is there anything specific about my hip or knee that is out of the norm? These are a couple X-rays and patient pictures. That knee has had about 4 different surgeries on it, right? That's going to be a little bit different than someone who's never had surgery on their knee before. That's a much more complex case, even though it's a quote unquote primary joint knee replacement. That's going to be a more complex case. They're going to be at higher risks for infection, stiffness, and other complications. It may need some different implants and than I would typically do. So that's certainly a different conversation than someone with knee arthritis. Same thing goes, say, for someone with a hip replacement, or who needs a hip replacement, who's already had surgery that's failed for something else. Again, those are things that you want to make sure that you want to have those conversations with the surgeon about, so that you can understand the specifics for each problem. I'll do a couple more slides and I'll go back to answering questions as well. One of the other common questions I get is, do you use robots? Okay. The first question I ask when people ask me that is, that's a great question. Why do you ask that? What is it that you're curious about with robots? I think intuitively as humans, we hear about robots and we think they're the end all be all. They are what everyone should be using for different things. And I agree, in some situations, they are fantastic. There's certainly some situations and specific cases that I would use a robot for. But I also, by and large, don't use them for most joint replacements, okay? Mostly because you don't need to use them. The outcomes haven't been shown to be any better with robots. And there are specific complications that can occur in robotic cases that I don't have to worry about when it comes to my cases that don't use a robot. So again, I'm not saying that anyone who uses a robot all the time is wrong, but they are a tool, and you want to make sure that you're using the right tool for the job. And the surgeon is only as good as the input coming out of the robot and using their clinical judgment. At the end of the day, I've certainly been a part of cases where we were planning on using a robot, and what the robot was saying didn't make sense. The alignment didn't make sense. So we had stopped using the robot and then went back to doing it in conventional means. So you need to be careful of what you're using and make sure that you're using your clinical judgment anyway. So again, they certainly get a lot of press. They get a lot of marketing. Certainly the companies that have the robots want to make sure patients are aware of them. But I mean, some of it is, to be quite frank, a marketing aspect from companies that use robots as well, in my humble opinion. So anyway, we can talk more about that too if anyone has specific questions. Same thing with implants. If anyone asks, what implants do I use? Again, I want to ask, why? Like sometimes someone was in the medical field beforehand, and that's why, or their friend had an implant and it did great, or friend had an implant and it didn't do good. and they want to ask why about that. By and large, I use implants that have very good track records. That's what I care about. There's certainly some specific cases that I may use one implant for that I don't use for another. In general, with knee replacements, I'm using either a Zimmer Persona knee replacement or a Smith & Nephew Journey 2. When it comes to hips, I almost always use the Smith & Nephew implants for that. Again, they have very good track records, and those are the implants that I'm most comfortable with. To go back to my comment that I made earlier about the surgeon feeling comfortable, if I was getting a hip replacement done and I thought, implant A was the best, but the surgeon typically used implant B, I would not want to be the first case the surgeon's using implant A on, okay? Again, I would want the surgeon to be comfortable with what they're using, because all the major companies have implants that are exceedingly similar. There's fine details and so forth. But at the end of the day, a well-done hip is a well-done hip, and a well-done knee is a well-done knee. And any of our surgeons here at Rothman will be able to do that for you. Then, I kind of touched on this before, but when patients ask, my friend or my dentist, had XYZ happen, I'm always a little hesitant to give too much detailed answers on these because I don't know the specific reasons, right? Oftentimes it's a game of telephone in terms of, Mary had two white cats to begin with, and then after it's been passed through a few people, it's Mary had 2 black dogs. So you never really know what the truth is. I'm certainly happy to give my opinion to people who have questions in that regard. But at the same time, I don't really know. Okay. Again, the complications that are most commonly discussed are the ones that I talked about before. And that's where it really comes down to the expectations and communication that you have with your surgeon to make sure that you're on the same page. Any complication that comes in, I can take care of. That's one of the reasons that's one of the things I got from my fellowship training. There's nothing I can't handle when it comes to hip or knee complications. I can do it all. I will say not every joint replacement surgeon can do that or will do that. Some people only do primary knee replacements or primary hip replacements, which again isn't, that's fine. And even some of the people who only do primaries, they used to do revisions, they just chose not to anymore. There's nothing wrong with that. But again, if you're concerned about that, then that's a conversation I would certainly have with your surgeon. And then what will recovery look like? We kind of talked on this a little bit previously in terms of going home. Like I said, you are going to have pain. Surgery isn't magic. Your knee is going to hurt. Your hip is going to be uncomfortable. I try to make sure that's very clear to patients beforehand, because I never want someone to think that, you're going to do this surgery and you're never going to have pain again. That's not how this goes. Okay. I did talk about, being a responsible or reasonable human. That matters a lot. You're going to have some days after surgery where you feel great. You're going to have other days after surgery that you're going to feel horrible. And that could happen for the first month. Okay. It doesn't mean that anything's wrong when you're feeling horrible any more than it means that you're doing better than everyone else when things are feeling great. The reality is typically somewhere in between. So I tried not to have you get too high with the highs or too low with the lows. The recovery will settle itself out, but it does take some time. Physical therapy, again, so for hip replacements, very few of my patients will get physical therapy. Knee replacements, very few of my patients go before 2 weeks. At 2 weeks, depending on how you're doing in terms of range of motion and so forth, I may have you go to therapy at that time. Early therapy, there's data supporting it. There's also data saying that actually, doing therapy on your own is more beneficial. But the bottom line is, again, I trust patients more than I trust other people. It's your knee. You're going to know how it feels. I don't want you to be having a miserable day and then you're going to therapy and then your day becomes worse. Your wounds also have to heal. And I don't want you to do too much too soon. That just perpetuates the inflammatory process or the pain as well. So again, we can get more detailed into that if you'd like to. But that in general is my answer for that. Standard, I will see people at 2 weeks post-operatively, 6 weeks post-operatively, and then somewhere between 3 and 6 months. Okay, those time frames vary. All right, the better you're doing, the least I'm going to see you. Okay. If you aren't doing as well or we're concerned about something, I'm going to see you more frequently. Again, some of that is just to make sure things are improving. Some of it may depend on the patient really wants to see me a little bit more. But at the same time, if you're doing very well, I'll tell you there's nothing else I'm going to do for you. right? Just be happy with your result. I'll let you know what to look for, but there's nothing that you should be concerned of in those regards. Just be thankful that you're doing so well. We can also certainly talk over the phone with my clinical team and share photos through one of the apps that we have as well. So, again, we're there to take care of you, but certainly in 2022, with the amount of technology that we have, being cared for doesn't mean that you always have to be present. If you just had surgery, it's not always fun getting into and out of the car and traveling. So we're here to help you in that regard as well. Last, along those lines, my treatment team consists of my nurse, Taylor. Joel is my primary scheduler. I also have another scheduler called Jasmine at the Bluebell office who works with me. And I will tell you, as in a whole, I speak to Taylor, my nurse, more than I talk to my wife. Okay. These people are my team, and we function like a close-knit family in many regards. And I do expect all of my team members to be treated with respect. Okay. I will not tolerate people talking mean to Taylor. If you want to be upset with someone for any reason, you can be upset with me. But she answers all the phone calls. She does all the care beforehand as well. And she talks to me a lot. So if there's any issues, let me know. But I certainly expect my team to be treated with the same respect that I would be treated with. And I don't think that's too much to ask. No different than I would expect each patient to be treated with respect by my team. So that's really all I had in terms of actual material. I really, like I said, I really do open the floor for questions, and I'm going to start going through some now as well. Certainly type anything that you have. I'm going to start from the top and work my way down. So if I repeat an answer, then we'll go from there. Okay. So Gail, in terms of physical therapy prior to knee replacement. So yes, we certainly recommend patients try physical therapy beforehand. I apologize, I skipped that before. On my lecture. Some people, their joints actually hurt too much, but they try it and they say, look, this is actually making me worse, and they can stop. But certainly physical therapy is a good thing to try beforehand to see if again, we can decrease your symptoms and help you out prior to surgery. Are we able to negotiate monthly payment for surgery? Great question. I don't know who asked that question. Great question. Again, that would be something that you'd want to talk to the finance office about. That may depend on insurances and so forth as well. So I can't answer that question for you. But certainly our finance office is as flexible as possible when it comes to things for patients to make things, again, as easy and stress-free as possible. Can you meet the surgeon before you definitively decide whether, oh, absolutely, Anne. So I would not want to operate on someone that I have not met personally, okay? Again, this is a relationship. So I would certainly want to meet you before whether doing a knee or hip replacement. I don't think I've ever, outside of trauma patients, I don't think I've ever done a hip or knee replacement without actually meeting a patient first. So certainly I'd want to have that time in the office beforehand to let you know my expectations, answer any questions that you had. And again, make sure we're really on the same page there. So absolutely, that the answer is yes, and Paulette, a surgeon told me he wouldn't decide if I was getting a partial knee or total knee until he got into my knee. So again, I don't want to speak for that surgeon. But one of the things, so partial knee replacements are when you're just replacing one compartment of the knee. It's most typically the inside aspect or the medial aspect. So the part of the knee that's closest to the other knee. Oftentimes, I have a very good idea in terms of what's going on. And I think I've only converted one partial knee to a total knee intraoperatively. I will always tell the patients that it's possible, okay? Now, and some of that has to do with if you're going to do a partial knee replacement and you're looking at the knee and you can see that although the x-ray looked fine or the MRI looked fine, you looked at, and they have really severe disease on the lateral part of the knee or the other parts of the knee. In those cases, you may decide, you know what, I don't think this part of the knee is going to work very well for the patient because of how much disease they have throughout the rest of the knee, and decide at that point to convert to a full knee replacement, okay? I can't say I've ever told a patient, I'll figure it out when I get in there. I doubt that's what the surgeon said or in that manner. If it was, I doubt that's how they meant it. Again, I don't want to put words in their mouth. But certainly, when I'm signing someone up for a partial knee replacement, I'll let them know that it is possible that we do a full knee replacement depending on how things look when I get into your knee. So hopefully that answers your question, Paulette. Gail, 48, currently active. Will you prescribe the physical therapist treatments to do so? Gotcha. So in terms of activity level and returning to activity, again, so it's a little bit different. Hips versus knees. Hips, I have 0 restrictions on what you do after 3 months. You can go, 3 months after surgery, if you want to work towards running again, or, jumping out of an airplane or riding a horse, whatever you want to do, go for it. Okay. Knee replacements, it's going to take you longer to recover. All right. So again, if you were a marathon runner, okay, and you want to go back to running marathons, I'm not going to stop you from doing so, but it's going to take you a long time. Okay. Again, I would say at least a year to build up stamina and to feel comfortable running that long in muscular strength. Also, a knee replacement is more mechanical than a native knee. Okay. So your knee after a knee replacement isn't going to feel like your knee when you were 20. All right. That's not what it's designed for. It's designed to help alleviate your pain to do normal activities such as, golfing, walking. Typically when people go back to tennis, they play more of a doubles tennis or paddleboard. Now, that's not to say that I don't have patients that are back to running. Okay. They can do that. But if that's your expectation, then I would be very open in terms of, that's what I want to get back to, so that you can have a conversation with your surgeon about that beforehand. It may depend, again, not just on hip arthritis or knee arthritis, but also some of the therapy and so forth that you do to make that happen. So again, I don't have restrictions necessarily on what you do after surgery, but can I say all of my knee replacement patients go back to running? Absolutely not. Okay. But some of that may be a bit more personal than not. Carrie, can partial tears in the gluten and medius be repaired? So to answer Carrie's question about partial tears in the muscles, so if you were going to repair those, I cannot repair those without making a very big incision from a direct anterior approach. You could do a direct lateral approach. You could do a posterior approach. Those would be a little bit easier to repair in that regard. That said, I've also done one case recently. I did a direct anterior approach. I made a separate incision laterally to do the repair in that aspect, and that patient did fine too. So again, if that's what's causing your problem, or you have 2 problems on top of one, that's certainly a conversation that you can have with your surgeon. You certainly can get a look at the glute minimus and medius with a direct anterior approach. But if it's a large tear or something along those lines, again, you'd want to plan for that preoperatively to probably make your incision in a bit different location. Can you maintain the original alignment of the knee? Gotcha. So you certainly can, if you're bow-legged or knock-kneed, you can maintain that alignment. You can also straighten the alignment of the knee to make it more straight. So if changing the alignment hurt you on one side, and you don't want to have your alignment changed on the operative side, again, just talk to the surgeon about that. Some surgeons are okay leaving that and giving you a bit more of a bow-legged deformity. Other surgeons don't want to do that, but it certainly would change what you're planning for during surgery. So again, I would have that conversation with the surgeon beforehand. But yes, you can change knee alignment for specific reasons, and it's not that challenging to do. So an anterior approach is through the front. So if you were to feel your hip crease, kind of where if you lift your knee up and feel where your thigh meets your abdomen, it's from that crease and it's down the front area of your thigh. That's what an anterior approach is. Weaning off of medications. We'll certainly give you a lot of different types of medications post-operatively. Many of those are some of them are narcotics, some are anti-inflammatories, some are Tylenol. One is a blood thinner. In terms of which medications, excuse me, you have to take as you recover, the only thing I really mandate is the aspirin or blood thinner that we would typically give you for 30 days. Outside of that, if you're feeling great and you don't want to take any medications, go for it. Don't take any, or you can take them sporadically thereafter. Again, this is one of those things where I want you to listen to your body and kind of see what you need to take in order to feel better. Are all the replacement parts the same size material? No. So the sizes are very different. you have sizes that are designed for very big individuals and sizes that are designed for very small individuals. The sizing, you can have an idea of before surgery. We do some templating, looking at the radiographs with some software that we have, so that we generally have an idea of what we can expect from a size standpoint. But ultimately, the size is determined intraoperatively. And again, that's all part of treating this specific patient during surgery to make sure that they have the appropriate sized hip or knee implants for them. So material, again, there are some slight variations. Most hip replacements are titanium of some type. They may have a coating on them or not, but most are mostly titanium. Knee replacements are titanium or cobalt chrome or some other type of metal. So there's a bit more variation probably within knee replacements than hip replacements. But again, there are specific reasons why you do something versus not when it comes to that type of thing. How do I decide between a cortisone injection versus a Synvisc injection? So Synvisc is part of that Viscosupplementation family. In general, I'd recommend someone get a cortisone injection first because that is our gold standard, okay? We have data suggesting that Viscosupplementation injections may work very well for some people, but there's a large number of people who they don't work well for either. Steroids are a bit more reliable in that regard. So that's why I'd recommend the cortisone injection first, because the Synvisc or the Viscosupplementation injections, there are a few more patients who don't do well. Now, having said that, if there was one injection that worked great for everyone, there would be one injection. But we have tens of injections. Okay, there's over 20 different types of Viscosupplementation injections. And maybe your friend had a Viscosupplementation and you want to try that, that's fine. I'm not going to argue with you. You can try that for sure. Just like when it comes to knee creams and different braces and so forth, you can get for your knee. There's a bunch of different products because none of them work great for everyone. So when it comes to non-operative care in that regard, there is a bit of trial and error that you have to go through. Are dislocations more prevalent with replacement parts more so than the original equipment? So I think what Sam's asking is, on revisions, are dislocations more common than when you get a primary hip replacement? The answer is yes. If you're asking if getting a primary hip replacement makes you more common or more likely to have a hip dislocation than if you got no hip replacement at all, the answer is also yes. So hip dislocations occur at a rate of about 1 to 2% of patients. Again, that's all comers. So there may be some differences there depending on patient population. Revision hip replacements, some studies suggest that hip dislocation is common in up to 10% of patients when it comes to revision hips. So there's certainly a difference there. But again, there's specific patient factors that can make someone more or less likely to have one than others. All right. I had a doctor do a knee replacement 9 years ago, was not very successful, 90-degree bend in pain all the time. Now I need a left knee replacement and worried about the same outcome. So Kathleen, I think that's a great question. And I would be worried as well. I would say the number one thing I would do, you can certainly go back to the same surgeon if you'd like and ask, why did they think that you didn't have as good of an outcome as you thought you would? Okay. Because if you're not happy with one outcome, right, you want to try to identify why you weren't happy to try to prevent that from occurring on the second knee. Okay. Having said that, it's kind of an interesting aspect of things, but when it comes to there's a bit of regression to the mean. If your first knee replacement, and I tell patients who are getting their second knee replacement done or their second hip replacement done, if they had an awesome recovery after their first one, okay, it's unlikely that they recover as awesome on the next one. It may be a slower recovery, all right, because they did so well the first time. If their recovery was slow on the first knee, then I expect it to be probably better than on the second knee because they didn't do as well as I would expect them to do on the first one. Hopefully that makes sense. And I'm not trying to overcomplicate things, but that is certainly a discussion I have with patients as well. Knees and hips are like children. You can do the same thing the same way on both sides, but you're going to feel different. Okay. You're going to have a favorite knee. You're going to have an unfavorite knee. You may have a favorite knee for a specific activity. Same thing with hips. You get both hips replaced, you may love them both, okay, much like you do children. But I can tell you from my own, there's a certain child like more for one activity than another. And typically when you get both hips or knees replaced, you will have one that you like more than the other for one thing, and one that you like more than the other for a different thing. So again, Kathleen, I can't give you too much specifics without seeing you in person. But those are some of the things that I'd have in the back of the mind. If you aren't comfortable with the answers that you're getting about maybe why you didn't have a very successful knee replacement the first time, I would certainly, find a different physician and talk to them or get a second opinion. There's nothing wrong with that. You get second opinions, third opinions, whatever you need to feel comfortable about what's going on going forward. What factors help you determine who is a good candidate for negative pressure? So I use negative pressure mostly. A wound vac or a negative pressure device is basically, it's almost like it's a sponge that we place on wounds to best or to try to remove any fluid and to stimulate blood flow and oxygen to the healing aspect. Very rarely will I use that on any primary knee replacements, simply because the results are so good without them. I don't think it's necessary. The more common on revisions or any surgeries that I expect to have a bit more bleeding, or where I expect the incisions a little bit more either longer or there's more soft tissue dissection. So those are certain things that I would do to that would have to put me in a negative pressure wound device. Do I do double knee replacements? Yes, I do bilateral simultaneous knee replacements. I also do bilateral simultaneous hip replacements. The caveat on that is, number one, I tend to only do them on patients that are less than 65, that are very healthy, or relatively healthy, don't have any major cardiac or medical issues that could strain or make the recovery a little bit harder. I also have to trust the patient, okay? I mean, if you're talking about bilateral knees, that's gonna be a harder recovery. I wanna feel comfortable that you're gonna be able to tolerate that and do well. In addition, if someone has bilateral knee arthritis that's severe and horrible, and both these kill them, and one hurts more one day, one hurts more the next day, you don't really have a good leg to stand on. So I feel a lot more comfortable doing bilateral knee replacements on a patient like that, and someone who may have some occasional minor pain on one side and has severe arthritis on the other side. In those situations, I would typically say, look, let's take care of the worst side first, see how you feel. And then, maybe if you're able to offload that other knee by having a functioning knee on the other side, you're going to feel better. So those are some of the determining factors that go into play. So if someone sees me and they want bilateral knees, and I don't think it's a good reason for any of the reasons I listed above, I'll tell them that. And I'll tell them my reasoning behind it, because ultimately I'd rather have one knee that did very well than two knees that did poorly, or someone who underwent a bilateral knee replacement and had a medical event. And that's not going to benefit anyone. So again, that's the reasoning behind some of my answers there. Weight limits or BMI limits to qualify for surgery. So in general, our practice has a BMI cutoff of 40. BMI is a measure of your weight versus your height. And any level above 40, we do not do hip or knee replacements on. Revisions are a little bit different because some people have very, life-altering challenges from those revisions. But for primary hip and knee replacements, we will recommend that you lose weight, simply because the risk of a complication increases exponentially when your BMI is above 40. And again, I know arthritis hurts. I know it impacts your quality of life. But having a joint replacement, say, that got infected, and then we can't clear that infection, is going to impact your life even more, okay? So the reason we have those cutoffs is for your own safety. And then we certainly can talk to you about different strategies to try to help alleviate some of the pain that you're having, and also help you lose weight to get that BMI below 40. And yes, there are exceptions that are made in special circumstances. Nothing is that black and white, but in general, above 40 is a pretty hard stop for our practice in terms of when we would do a hip and knee replacement. I've had 7 steroid injections. Is there a limit to how many I can have? I've been told that I'm too young for a hip replacement. So there is no hard limit on steroid injections. I will say that there is data showing that there may be a cumulative effect, meaning that the more steroid that you get, the faster your arthritis progresses. Some of that may be because you have arthritis and it's progressing as it is. In terms of that whole, I'm too young to get a total hip replacement or a total knee replacement for that matter, I think very few of us who actually do hip and knee replacement, even that, I have a really hard time, you stated your age was 46. I have a really hard time looking a 46-year-old in the eyes and saying, look, just be miserable, okay, with the hip arthritis that you have for the next 25 or 30 years of your life. And then when you're old enough and don't feel like doing anything, or, your kids are out of the house and you've missed some prime years of your life, we'll talk about it, okay? To me, it's relatively immoral to tell someone to just continue to be miserable from 46 until they're 70 just because of an age. There's a lot of factors that go into deciding hip and knee replacement. Age is one of them, but so is health and quality of life. So I've done hip replacements on patients much younger than 46 for specific reasons. I've done hip replacements and knee replacements on patients as old as, older, well into their 90s. So again, there's different stages of life that people go through. Our job is to help you. Okay. So I don't think you're too young for a hip replacement, but again, there may be some other factors there as well. But I don't have a hard cutoff for age or anything along those lines. To me, it's about quality of life and severity of disease. If you've done everything else that I could ask you for, then we can have that conversation. Is all the hardware now all dual mobility or cementless? Dual mobility is a specific type of hip replacement that has a ball and a ball. It allows you to have a bigger functional head. I will use that selectively in some patients. I do not use that for the majority of mine, simply because my dislocation rate is exceedingly low with not using that. And as we've learned over and over in orthopedics, sometimes we over-engineer things, such as what happened with some metal on metal hips. And we thought they were great, and then longer term they turned out not to be great in some instances. So if you're going to use a specific instrument or a specific tool, you want to have a reason for doing that. And so I don't think any of us here do dual mobility on a lot of our patients. We will selectively, but certainly not most. Most of us do cementless implants for hips. Most of us do cemented implants for knees. Again, there's variation. I do cemented hips as well. I do cementless knees as well. But there are some patient factors that go into that. And then neck length for standard length, that kind of varies depending on your anatomy. So that's challenging to answer in a live form. General anesthesia. So most of the hip and knee replacements now are done under spinal anesthesia. So you don't have a breathing tube that's placed for you. We want the patients to breathe on their own. Some people do require general anesthesia, and that's okay as well. But the spinal anesthesia is when you get an injection into your back done by anesthesia. You're numb from the waist down for an hour or two, and then it wears off, and you're able to tolerate surgery. You don't feel anything, and then it wears off, and you're up and moving about thereafter. So that is generally what we do for anesthesia. Is the knee heavy? It's a great question. The implant weighs probably about a pound more than the bone or the material that we remove. So no, it's not heavy. It shouldn't feel heavy. Outside of the fact that after surgery, your leg is going to feel heavy in general, secondary to the swelling and the fact that your muscles don't want to work quite as well. Is it wise to try to lose weight if you're overweight prior to knee replacement? Yeah. So again, some of that's a personal decision, right? I think if you are, have a BMI around 40, I think from an overall health standpoint, it's probably going to benefit you to lose weight. The recovery, it certainly does decrease, again, when you're looking at someone with a BMI of 50 versus a BMI of 20 or 25 for that matter, you're going to have lower complication rate with the BMI of 25 versus 50. Is there a big difference between 30 and 28 or 36 and 34? No. Okay. But in general, we want you to be healthy as well. That's the whole point of doing the hip and knee replacements, again, is for quality of life, and part of quality of life is overall health. So weight loss may be part of that, but again, that would be a specific discussion you should have with your surgeon as well. Cardiac with a biventricular device, my electrophysiologist with ultrasound, scheduled up in ultrasound, should I be staying at ultrasound hospital? I don't think any of our joint replacement hospital, so if you were to go to the Doylestown Surgery Center where I operate, you would not be you would be going home the same day, and you would not be going to Doylestown Hospital. So someone with who has a cardiac history with a biventricular device, I'm not going to do it at a surgery center, simply because I'd want a larger tertiary care facility like Abington, where I operate, or Jefferson Hospital down in Center City, that could take care of you or monitor you if you needed that type of support. So again, that's the type of patient I probably would not recommend doing at a surgery center. For programs. All right, well, thank you for your comment, Lisa, and I wish you the best of luck. Discuss quad sparing knee replacement. So quad sparing means you aren't cutting or transecting the quadriceps tendon. In terms of how you get into the knee, the quadriceps tendon comes down the center, and then we come to the side of it. So I think that's what most surgeons are doing. The quad sparing in general, so that's actually been studied in great depth. There's been shown no difference with whether you cut the quad, cut part of the quad, cut all the quad, don't cut the quad at all, in terms of your functional outcome or your recovery. So again, that was largely a marketing thing that was promoted. And then we actually looked at it and we found no difference over and over and over again. That being said, no, I don't transect the quadriceps when I do it, but there's nothing wrong if you do. So it recovers just as well as anything else. No left hip. I need a left hip replacement and a right knee replacement and arthritis in my back. Gave me a quarter shot. My hip hurts worse. So in terms of if you have hip arthritis and knee arthritis, what should you have done first? Our study suggests you should replace the hip first and then work on the knee. Sometimes you can have hip arthritis pain that's actually referred to the knee, and it feels like your knee is bothering you, but in large part it's coming from your hip. I probably see about one patient a week that gets sent to me for severe knee pain. I look at their knee, look at their x-rays, it looks fine. I examine them, and I'm like, we should get an x-ray of your hip. And it turns out they have severe hip arthritis, and they get a hip replacement and they do well. So, that's one of the reasons we recommend doing the hip first and then working on the knees from there. So if they hurt you about the same, then I would certainly do the hip first and then the knee. Sleep apnea is fine, unless it's severe sleep apnea. But most types of sleep apnea are fine to have done at a surgical center. That's not a problem. And thank you for that comment, Gail. Does anyone else have questions? I know it's 6:30 on a weeknight, so I don't want to take up anyone's time unnecessarily as well. But I certainly the whole point is to answer any questions that you have. And hopefully this has been relatively helpful to give some general ideas of common questions that patients ask and provide you guys a platform to develop your own questions when you're talking to your surgeon about your hip or knee.